All right, thank you. And please do not be sick of my face. Please do not switch off or block off my face. I promise you, this is the last time you're going to see me until the end of the dinner. Okay, so my role now is as the moderator of motion one of our debate. And we are going to begin our grand proton therapy debate this evening. Well, as I've mentioned before, this promises to be a very exciting debate. I believe I haven't seen anything like that in the region, at least, or everywhere, a debate where we have speakers sparring with one another from both ends of the fence. And mind you, I to be honest, okay, I haven't looked at all the videos. They have been pre-recorded, but I have to say, looking at snippets of them, some of that, the debates can be quite fiery and they can be quite yam-sing, in my opinion, right? So they can be very, very feisty. Let's brace ourselves to hear from our experts today. Now, a brief introduction as to the format of today's debates. We will have a motion, okay? And the motion one, what better way to start our proton debate with the motion that proton therapy will be the standard of radiation care in the future. A very provocative topic, and we look forward to hearing from our two speakers. We will have a proposition and an opposition from both sides of the fence. Okay, and we will start off with both speakers delivering an opening speech, or what I would call an opening salvo, which will last 6 minutes each, following which we will then listen to a rebuttal from each of the speakers on their counterpart's speech. So basically what has happened is that the speakers have recorded their speeches once, and then we have exchanged speeches and sent their counterpart speeches to each speaker to then watch and to prepare a rebuttal. So that will be the second segment of our debate, where we have each speaker rebutting for 2 minutes and summarizing their viewpoints, following which we will then open up to the floor for 5 minutes of interaction between all of us present. So you can feel free to type your questions in the chat group and or also to unmute yourself and ask questions, right? And what's more, the speakers will not only be here in spirit, they will be actually here present with us in this Zoom meeting live. We have already seen Professor Das and Professor Hoyer with us and watching the show. So they will be here to answer all your questions in the final segment of this debate. Right, so let's begin by hearing the proposition speech from Professor Das. His biographies, okay, speaker biographies have now been posted on our website. You can look at the chat group, you can open the link and you can read a little bit more about them. So just allow me to give a brief introduction to Professor Das as he begins his speech. Dr. Das is an internationally acclaimed medical physicist with expertise on radiation dosimetry, small field dosimetry, treatment planning, MRI, LINAC, and proton beam therapy. Dr. Das has worked in major academic centers, University of Massachusetts Medical Center, Fox Chase Cancer Center, University of Pennsylvania, and the NYU Medical Center. He has published extensively with over 200 to 300 papers and books under his belt. And he's currently serving in the editorial board of the IJROBP and the Journal of Medical Physics. So without much further ado, let's welcome Professor Das as he delivers his first opening speech for the motion, proton therapy will be the standard of radiation care in the future.
Welcome from Chicago, and thank you for inviting me. I hope you guys have a nice dinner. I wish I was there. So let's talk about this debate about the proton. A very good article just got published in JACMP. It's talk about the same issues we are talking about, the pros and cons of proton beam therapy compared to the photon. Our cardinal belief is that the maximum dose should be to the tumor and minimum dose to the organ at risk. Dose distribution should be based on the deviation. Particle beam has certainly advantages in terms of range. And if the dose is a surrogate, then proton is a winner, which is not a questionable. But if that is the case, why it is not translated? Well, it's because the technology, know-how, and cost. Now, looking at the dose distributions for a single beam, everybody knows that photon beam has attenuation properties, whereas the photon beam has a finite range. So looking at the dose distributions, you can see that SOBP gives uniform dose and lower dose to the skin. When you look at it in parallel opposed situations, you see that photon beams gives a very high dose to the sides, and proton beam gives lower dose on the sides and highest dose in the center of the tumor, which is what was desired. Looking at the pictorial for the dose distribution, this paper is from Boston. Proton gives a uniform, not uniform, but it's uniformly radiating the whole body. Electrons, the partial body, and protons, it's only to the spinal cord for this pediatric case. Looking at the dose distribution, if you put the proton beams 3D and in the head case, you can see that we can spare all the critical structures in the proton cases. Looking at the breast, you see that proton, it provides a lot of dose to the contralateral breast and dose to the structures of the heart, whereas in a proton beams, we can actually spare all those aspects. You see there is no dose to the critical structures. Looking at the SBRT, the same, you see the whole body dose here, and in proton, there is no dose. This has been summarized by Professor Langenbeck in terms of the TCP and TCPN outcome, and he concluded that proton beam has a better theoretical outcome. We provided the data for the intensity modulated and why the technology is not there, and some of the aspects I'll discuss with you here. So in IMPT, we need to know about the range uncertainties, robustness, algorithms, spot size, energy switching, dose rate, imaging, motion management, RB, and clinical outcome. The cost factor, you can't read all these things, but here is the fact, is that carbon to photon is 4.5 and proton to photon is 3.2, which is significant. Limitations are that uncertainties in physical and biological uncertainties are significant, and we need to know that. Spot size is a big problem. Energy switching is a problem. Imaging in room is a problem. Respiratory motion needs to be addressed. Algorithms needs to be addressed. And cost. Cost is significant. The machines, the manpowers, and operational costs of these machines. Looking at the secondary malignancies, this data provides very good information about the modalities, VMAT, proton, IMRT, and 3D. And you can see that the proton beams have the lowest probability of the secondary cancers. So take-home message is the proton beam is a fast-growing treatment modalities, complex and costly. More research in productions, planning, and motion management needed. Imaging tools, proton radiography, and a lot of things are coming up online. Better PR in community and clinical outcome data to convince critics. And thank you very much. This slide was taken at your hotel in the front of your garden. And I want to take some questions. I'm sure that we will have the lively debate. So thank you very much.
All right, thank you. I'm still trying to chew and finish my food. But anyway, thank you very much, Professor Das, for your opening speech. And what we have now is to hand over the time to Professor Hoyer, who will then give his opening speech as the opposition for the motion proton therapy will be the new standard of radiation care in the future. Just a very quick introduction of Professor Hoyer, who is a friend of mine. He is Professor and Medical Director of the Danish Center for Particle Therapy, and he specializes in radiation therapy of brain, liver, prostate, bladder, and childhood cancers. Professor Hoyer is very active in the ISTRO and IAEA scene, and is currently establishing an educational and training program under the European Network for Particle Therapy. So without much further ado, let's invite Professor Hoyer to give his opening speech.
My name is Morten Høyer. I'm the Medical Director of the Danish Center for Particle Therapy. Thank you very much for inviting me to this debate. During the next 6 minutes, I'll try to argue that proton therapy will not be the new standard of care in radiation therapy. I know that you're sitting at a very nice dinner. Do I have a difficult task then? Absolutely. And even I'm a great fan of protons. Why is that? That's because of the very good dose distribution we have with protons, where we have less dose before the target, no dose after the target, and even a very delicate way of delivering the dose. Do we have the evidence for protons? Unfortunately not, at least not yet. There are even randomized trials on protons contra photons. It's one example is this one in inoperable non-small cell lung cancer, randomizing patients between passive scattered protons and modern IMRT protons. It failed to show that it's an advantage when it comes to radiation pneumonitis. There was the same local control in these two arms. It doesn't necessarily mean that there's not an advantage of protons here, but it just shows you that this study, which was conducted at one of the expert facilities, did not show a difference. And it shows that it's extremely difficult to conduct such a trial. There are a lot of planning studies showing an advantage to protons over photons. This example is from Denmark. It's in breast cancer. And it shows that you can have a very good coverage of your target, the breast and the IMN, and even with a very low exposure of the lung when you use protons. So there is an advantage, but is this a proof of protons as a preferred treatment? No, it's not, because we don't know if this translates into meaningful clinical outcomes, such as reduction of cardiac events and reduction of risk of secondary cancer. And beside that, the robust protons are less robust. I'm sorry, the light went off. It's here again. There are day-to-day variations in the patient, motion during the treatment, air cavities that can be filled and empty. And then there are range uncertainties in the way that we calculate the dose on our treatment planning systems on the CT scans. And there are RBE uncertainties. I will just look a bit on that, because there's a conversion between photons and protons. Protons are 10% more efficient, so there's a factor of 1.1 when we calculate the dose. And the problem, there's a large distribution of these studies that were used. They were experimental studies for this conversion factor. And this means that there's some uncertainty here. And it could be 5% larger, most likely, or it could be even lower. And it depends on the dose and fractionation, tissue type, and even the position in the beam. This is the position in a beam thing, because at the end of the Bragg peak, there's strong evidence that there's a higher biological effect here. This is because of the increased density of ionization in the end of the Bragg peak. And there's also some clinical evidence that this is the case. This is one of them, showing changes after treatment with protons in patients where you didn't expect it if you looked at the physical dose distribution, as is the case here. But if you looked at the LET weighted dose distribution, the biological kind of dose, and combine that with a higher sensitivity in the brain tissue close to the ventricular area, then that can actually explain why we see these factors. So we believe that there's a need of studies, and that patients should be treated as part of clinical studies when we are using protons. These are the studies we are running now in blue. The green are those that start within a few months, and the red is one that we have in a planning phase. So my conclusion is, and I'm sorry I didn't show it to you, I didn't have the time for it, that there's obvious advantage for protons in children because of the reduced risk of morbidity and secondary cancer. But there's still a need to have more evidence in adult patients. So my conclusion is that proton therapy will not be the new standard of care in radiation therapy in the near future, but hopefully in the longer run. Thank you very much, and enjoy your dinner.
Thank you, Morten, for the very interesting talk, and Professor Das as well. We move on to the second segment of our debate, and I'll not hold you back any longer as we now move on to hear Professor Das's rebuttal of Professor Hoyer's opening speech. So, Professor Das, please.
Thanks, Professor Martin Hoyer, for very interesting observations about the randomized trials, outcome data, and know-how about the technology and radiobiology. So just to end the rebuttal, I am going to provide some facts about the outcome. Professor Weber from PSI, he provided the data indicating that chondrosarcoma sarcomas with a proton beam has a very high outcome, as you see from this data. Similarly, for HCC, if you look at from Japan, the data indicates that it has a superior. Now, in the case of breast, you see that the data here indicates that. So there are, in every disease sites, we know that we can do far better job. Now, question is that clinical trials, these were written in 2007, and there is a lot of data available. Obviously, people blame these data to the media and ourselves. The next was that Herman Soot, when he talks about the clinical trials, and they felt that there should not be any clinical trials. The reason is that we don't need randomized trials between a kilovoltage and megavoltage and any other modalities when we know that it's a superior. So thank you very much, and I can take any question.
All right, thank you, Professor Das, for your rebuttal. And now we move on to hear Professor Hoyer's rebuttal of Professor Das. So, Professor Hoyer, please.
Thank you. And thank you, Professor Indadas, for your presentation. It's, I think we agree on very much of what you said. And I think we all believe here that protons are superior to photons in many cases, in many patients. What I say is that we really also need to show it in clinical trials. We know from comparative treatment plans that protons are often better than photons when it comes to dose distribution. But what we can really spare is a low dose volume, not the high dose volume. I think it's important to say, because of the issues that we have with protons, it is just not another type of X-rays. So for that reason, ladies and gentlemen, I really recommend to start up doing proton therapy as part of clinical trials so that we can convince everyone that it's the right treatment for selected patient groups. Thank you very much.
All right, thank you to both speakers for their wonderful presentation. We were having some comments that this debate is still quite civil and quite respectful. And we are thankful to the speakers for giving us a nice mellow start to the evening. But that's not all there is for today yet. There's still an open session where we will invite our speakers online once again to take any questions from the audience. So let's invite Professor Hoyer and Professor Das online with us.
Yes, I'm here. Can you hear me?
Yes, we can all hear you. Hi, Morten. Good to have you with us, and thank you for taking the time to join us. Yeah. Okay, so we're going to open, and I'm just waiting for the screen because there is a layout where we will have both speakers online as well. And basically what we're having here is some questions, some comments on the chat group, actually just one. But let me just read out what Brendan Chia, Dr. Brendan Chia has raised as well. He says that after hearing your speeches, it seems like once we get past the steep learning curve, protons will be superior across the board. So this is a comment from our audience. Any thoughts from our esteemed speakers today?
Well, I can talk to you about the know-how or the experience is very critical because proton beams are very complex. There's absolutely no doubt the protons are superior than photon beams. And when it comes learning, I think your person who asked the questions. He had a very good understanding that it's a complex problem and we need to know how this technology works. So I think I respect Professor Hoyer's comments, but it's just because we don't know how to use the proton beam.
Yeah, I really agree with you. It's right. There's a lot of things that we should learn to utilize better. We have, I mean, the dose distribution is really superior in many cases. I think I think and I think you also agree with me. There's a lot of places where we can still use photons with the same kind of outcome that we can get with protons. So our task will be to find the right patients for the right type of treatment. I think it's important that we will see some trials that can really confirm that there's the reduction in dose, that what we can see from dose volume histograms translate into clinical outcomes, reduction of morbidities. I think that is extremely important, at least here in Denmark, to ensure a sustainable referral of patients to our center. This is the way that I can convince my colleagues in the oncology centers to refer the patients here. And I think this is what we are struggling with in a lot of centers. We need to prove that the reduction in dose to the lowest dose, intermediate dose volumes translate into meaningful reduction in morbidities. We might not need it for any tumor type, but we just need to show it. For instance, in head and neck cancer, also in lung cancer. I'm really so. I'm really. It's a great. I mean, loss for me that we did not see it in the lung cancer study that I just showed you as an example. There's a lot of explanations for it.
Thank you both for your comments as well. I just want to raise another question. I took a bit of time to try to understand it, but I think I get it now. The question is a little asked in an indirect way: is there an advantage of driving a Ferrari on a 60 kilometers per hour road? Is there an advantage of driving a Ferrari on a 16 kilometer per hour road? And of course, there have been some discussion, and someone has said you do that to get admiring looks. So anyway, yeah, that's the view of the audience and the discussion that's going on. Any comments from our speakers?
Very good question. I think that I agree that you don't need a Ferrari, but the status and look, I think, as you mentioned, is a good thing. So, but you never know whether the road will be 60 kilometers or it may be 100 kilometers. So you have no idea. So I think I would not just discourage you not to drive on that. As you pass that 60 kilometers zone, you know, you may be faster and you may enjoy the ride.
Exactly. I mean, a Ferrari is not good for off-road, but definitely I had never been riding a Ferrari, but there are, I mean, you have the right car for any purpose. The same with X-rays and protons.
Thank you very much for both speakers. I just want to give one final question. And I think the last few questions in the floor is pretty much summarized in the question by Dr. Bala. And the question is, protons have been around for a good 10 years. Why has it been so difficult to generate the evidence? Any thoughts?
Well, I think the problem is that it's expensive, and most people, they want to treat patients. They don't want to publish data. That is the sad part. I agree with the Professor Hoyer that we should publish, but unfortunately, because of the cost associated with that, people are discouraged. So I would strongly suggest that it's not because we don't have the data. We just have not put our mindset to do that, and I think we should. And I again thank Professor Heyer for interesting, and we both agree on the same thing. It's just a small minor differences. Thank you.
Professor Hoyer, your closing thoughts.
Yeah, I agree, and has been really enjoying listening to you, Professor Das. I think there's one thing here. It's not a great business case to do randomized trials because you need to convince a patient to go and you have to tell about pros and cons for entering a clinical trial. And some patients actually end up getting the photons and not the protons that you are testing as a potentially better treatment. It's much, much easier to say to a patient, I have this better type of radiation therapy and you can have it. And even here in Denmark for free. So it's much easier to treat patients outside of a clinical trial. But I think we must do it in some cases. And here it's one of the tasks that we have to do clinical trials and to introduce protons as part of clinical trials. And this is what we try to do.
Thank you very much, Professor Hoyer, for the comments. And I think you raised a very important point. I mean, there was an issue about economics, and if the treatment is free and it's better, potentially better, why not? And I think we look forward to the second debate as we discuss a little bit more about the economics of proton therapy. But let's leave it as such for now as we move on to our next segment. Once again, a very big thank you to Professor Das and Professor Hoyer for gracing our event. And we greatly appreciate your inputs and your scientific rigor in this debate. Thank you very much. And we'll hand the time back to our MC.